И слово для следующего сообщения хотел бы представить Янсу Фихлеру, профессору, директору отделения диагностики интервенционной нейрорадиологии, медицинский центр университета Гамбург-Эппендорф.
Thank you. Привет. Доброе утро, дорогие коллеги. Let's start. So the subject of my first talk is stroke trial update. What have we learned and where are we heading with the new studies? My disclosure. So this is a short overview about what kind of evidence we have for thrombectomy. So I think we all know that proximal artery occlusions are 100% indication for thrombectomy. Basilar occlusions moved into this direction. Patients with very large infarcts, low aspect score patients, not so sure about that. And distal occlusions are unclear, low NIHSS, so few symptoms also unclear. This was February 2022, so last year. Where are we now? When in March there were a lot of new publications on basilar artery occlusions, on low aspect score, and a few other subjects. And I would like to share with you the results of these studies in case you are not aware of them. Let's start with basilar occlusion. This is Hermann Zeumer, my academic teacher, and he was actually the first who did intraarterial fibrinolysis in stroke. What you see here is a distal embolus in the basilar artery, and he used streptokinase with a handmade, self-made microcatheter and fibrinolized the clot. And it was the first successful treatment, and it's more than 40 years ago. So it took 40 years to have the first real randomized study on basilar occlusion. It was 2020, and there was a randomized trial with 131 patients randomized, but a lot of crossover. So 20% of the patients who were assigned to the IVT therapy, IVT treatment arm, secondarily went to the endovascular arm. So if you look at the original study, you have a therapy effect of 10% intervention versus control. And if you look at how the patients were actually treated, it was 22% therapy effect. So you had 74% good outcome, MRS 0 to 3, in the interventional arm, and only 24 in the control arm. But the problem was it was initially negative, and then we had the basic study organized by the Mr. Clean, not the Mr. Clean group, but another Dutch group. And you see there is much less of a difference. Endovascular versus medical care, only 6.5% difference. There were a lot of problems with this study. So we are very lucky that we have new data now from China. It's from last year. And this is the attention study. It's 0 to 12 hours after symptom onset. And with patients with NIHSS of 10 or more, 32% received thrombolysis. So what's the result of this study? Thrombectomy versus control, you see it already, MRS 0 to 3. We have 46 versus 23%. So a plus of 23% better outcome with thrombectomy. So first 12 hours in China, NIHSS of 10 or more, you have a very strong therapy effect. What's interesting about this is the higher the NIH, the higher the therapy effect. The therapy effect was also higher in patients without IVTPA. So IVTPA somehow works in the posterior circulation. And then the therapy effect was also higher in the lower PC aspect. So if you have less damaged tissue, you have a higher therapy effect. So PC aspect is an aspect score for the posterior circulation. This is an image, what you see here, PC aspects. You just summarize different regions also to 10, so pons, cerebellum, midbrain, thalamus, and posterior territory. And this is has been used also in the other Chinese study, which is the Baoche study. This is 6 to 24 hours after symptom onset. NIH also more than 10. So this is the later time window study from China, also randomized study. And the result is almost exactly the same, 22%. So just think about it. 0 to 12 hours or 6 to 24 hours, it's all the same. Thrombectomy works in basilar occlusion 0 to 24 hours. If you do, if you treat patients with more than 10 NIHSS score and patients with where not everything is damaged. Same observation here. And if you put the studies together, the location of the occlusion, proximal, middle, distal, proximal, middle, distal, proximal, middle, distal. And what you see in almost all studies that you have the highest therapy effect of endovascular therapy in proximal occlusions. Why? Most likely because you have longer clots and a higher percentage of intracranial stenosis. So if you have a distal occlusion in the basilar, it's more susceptible to fibrinolysis. So most likely this works nicely even with IV TPA. But if you have contraindications, obviously you can do thrombectomy. But the effect is the highest with the long clot. If we compare all the studies, what stands out is that in the BASICS trial, the Dutch study, they had way too good outcomes in the best medical treatment. All the others, all the other Chinese studies were more or less on the same level, but not with the BASICS study. And this has most likely to do with patient selection. So we are pretty clear that now after those studies, we have 100% proof that thrombectomy needs to be done also in the posterior circulation. Let's get to the next subject, to the low aspect score patients with the large infarcts. So we have 6 randomized trials. 3 of them are published. I'm going to talk about them in a minute. And 3 are going to present it very soon. 1 Tesla study is going to present it next Friday, so in a week from now, during the European Stroke Organization conference, and 2 are going to present it in Toronto next autumn. And this is is our study. But let's start with the published ones. Rescue Japan, randomized trial, thrombectomy versus medical care in patients with large infarcts, aspects 3 to 5. Result, 31 good outcome in endovascular and 13 in medical care. So superiority, no question. But I think one aspect is also interesting. If we look at MRS 5, we also have 18% of very, very poor outcome patients who are disabled severely, have a very poor quality of life, and 39% in the medical care group. So this was one of the points that was always the question, okay, maybe the patients survive, but you rather create kind of zombies, but that's not the case. So we have many fewer patients in the endovascular group who are severely disabled. So this is very good. But the problem with the study is this Japanese study, only 14% were based on CT. All the rest is MRI selection. IV TPA only in a minority of cases and in a different dosage. So it's a Japanese dose, less per kilogram body weight, and quite a few very, very early patients. So there we have new studies that have been published 2 months ago. The SELECT-2 study, an MRS 0 to 2 this time, so 20% good outcome here, and 7% good outcome in the medical care group, also highly significant, same effect on MRS 5. But then there was a question, this was very much focused on CT perfusion, and now comes the real, I think, the real surprise, not necessarily for me, but for many. If you look at the SELECT 2 results, and this is maybe one of the key messages of my talk here, you look at the core volume of less than 70 mil and more than 70 mil, there's not much of a difference in the therapy effect. So it's actually the other way around. If you have a larger core volume, your effect is bigger. If you say, okay, my threshold is different, less than 100, more than 100, no difference whatsoever, and less than 150, more than 150, you have, again, no difference in the core size. So what does it mean? It means that CT perfusion doesn't really help in patient selection. It's a prognostic factor, so the outcome is worse with large core, no question, but you cannot influence that the patient has a large core or not, but it doesn't help you to detect the patients with the highest therapy effect. I think that's a very important message. Okay, finally, Chinese study again, angel aspect from our friends from Tiantan Hospital in Beijing, and 30% good outcome with endovascular, 11 with medical management. So it's also very similar, also superiority again with the large core. So we have 400 patients in all those studies with aspects 3 to 5. So where does CT make still sense? So what we looked at, so we published it last year, it makes a lot of difference whether you have a dark gray infarct or a light gray infarct. And the threshold seems to be a net water uptake of 9%. So shades of gray might play a role, but it's a bit early to make final conclusions on that. Okay, so we have now the evidence on low aspect score also need thrombectomy. More patients to treat, also with large infarct cause. CT perfusion doesn't really help. Next subject here is IV-TPA. Do we need additional IV-TPA? And there are 6 studies who randomize patients with and without additional IV-TPA. And the differences are huge. So the effect size is either you are 7.3% better or 7.7% worse with the combination or not. And if you put it all together, you end up with a point estimate of minus 1.9% in favor of combining IV-TPA and thrombectomy. And I think this is interesting, and I don't want to go too much into detail with the approval consequences, but if you think about the therapy effect of thrombectomy, we read about 20% and so on. So 20% is thrombectomy alone, and 2% additional effect maybe is IV-TPA. That's quite interesting to think about. I found this very nice picture on Twitter. So thrombectomy, that's the effect, thrombolysis and thrombectomy. But there is still an effect. You don't want to be hurt by leaving this out. And we had a look at the data ourselves with a large database, and we have aspect score of 1 to 10. And then what you see here is if you give additional IV-TPA, the curve is different than direct MT. So what does it mean? In aspects of 0, 1, 2, you have a worse outcome with IV-TPA, most likely because you increase the risk of bleeding in those patients. And in aspects 10, so small infarcts, you improve the outcome with IV-TPA. So IV-TPA good in small infarcts and bad in large infarcts. So this could become interesting for the study. Okay, so further study here, collateral score. this is Mr. Clean Late, has been published very recently, a few weeks ago as well. And what you see here is 4 different patients. This one has almost no collaterals on the left, and this one has very good collaterals. So collateral score 0 and 3. And what the Mr. Clean people did is they randomized all the patients who didn't have a good CT perfusion for patient selection beyond 6 hours, no aspects restrictions, and they just included patients with a reasonable or good collateral score. I don't want to go into detail here. And what's the result? Result is what we would have expected. So there's, if you do intervention, you have a better outcome in the Mr. Clean Late cohort than if you don't do the intervention. So bottom line is you can skip CT perfusion and just use collateral scoring if you want to select patients also in the late time window. So the new study evidence, if I may summarize here. So there are a few other interesting studies, but I think that's good enough for today. We have these basilar studies. There is superiority in the Chinese studies, and there will be no other randomized trial in Europe, I hope, or in the US on basilar. So basilar is done. Thrombolytics, we stick with IV TPA. There is this add-on 2%, and the European recommendations say that's enough for us. We have the low aspect studies, rescue, angel aspect, select 2, and it showed superiority of thrombectomy also in the large core patients in several geographies. And finally, in the 6 to 24-hour patient selection, collateral scoring seems to be sufficient, or maybe even we just need non-enhanced CT, because if you can treat an aspect score of 2, 3, why do you need additional collateral scoring? Because this is the latest study results. Thank you very much.
Thank you.
Thank you very much, Jens, for your very interesting presentation.